Good afternoon. It's a distinct pleasure to be here today. Thank you, Dr. Anuradha and Pratik, for giving an opportunity to present ourselves for the dynamic biomarkers that would have actually immense role in minimal residual disease. I think this is an era of precision oncology, and we can debate, discuss the role of dual biomarkers like circulating tumor cells and ctDNA in variety of the progression of disease longitudinally. I would like to speak few lines about past circulating tumor cells, what it has done, how it was approved, what are the most important prognostication outcome. And I would also like to see the power of these dual biomarkers, what they can do. Instead of talking about MRD, I would like to talk about a minimal cellular disease, because all of us know that 90% of patients, they carry metastatic signatures, and PET scan or CT PET scan cannot detect it. So our assumption of a disease-free is on the basis of actually the limit of detection by the imaging systems. And we know that in breast cancer and colorectal cancers, this kind of a biomarkers are actually proving important role in order to enhance the overall survival. And I would like to present our OncoMonitor test data in lung cancer on 265 patients. And if time permits, and if Dr. Anuradha permits, I will actually go ahead. So, innovators, treating cancer is the highest ability of an oncologist, and nobody better than you understand how to deal with the oncologist, the patient. While we do that, we want to also actually found companies, innovate, and be as an kind of a global village in terms of an Gandhian engineering. The term that brought as an Swadeshi. I would like to actually mention that what Gandhian philosophy of engineering is, even in designing materials which can be capable of recognizing such very low abundant cancer cells which are hiding into billion of other cells. And that has been done by Western country, keeping the capacity to detect these kind of cells. If you look, the labs that actually work like OneCell or Actorius, we are all dependent upon actually importing components. And I'm sure that the whole end of a session that we will talk about affordability, accessibility, and availability without innovating in this country. So I dare to say that we have been here for 11 years. We have been publishing. The main domain is to actually innovate, file patents, not for, as an incremental innovation, but to be a leader. I'm going to talk about one of a small innovation that what we have done, but it is small in terms of actually what we do, but it's going to be a very, very phenomenal and incremental, not by an hypothesis, but by some of the data that I would represent. I think cancer's critical problem, everybody knows it. That MDR, especially if you consider 5 years of an relapse that what we see, in spite of a surgery or resection or taking care of a margins. So why do patients come in the clinic? In spite of actually the surgery has been perfect, the chemotherapy has been great, your RT has been very, very responsive. Prime and prudent reason of actually patient coming back in recurrence from remission is circulating tumor cells, because these are live fugitive cells that are actually running around. Only we didn't have capability to recognize their role, whether they are in different transitions or not. I think cancer dormancy, especially in the breast cancer, we know that the patient can remain in a remission for decades, and they would come back with the metastasis. MRD is a new toy in the town, and all of us know that in early stage detections to late stage detections, the role of adjuvant therapy, especially in de-escalation, is very, very important as far as India is concerned. And if you look at a graph for detecting this kind of a biomarkers is at the epitome, at the high level. When we take care of a patient, most of the biomarkers, including our protein biomarkers, they go down. But why do they come back? And I think Dr. Prashant will agree here that circulating tumor cells probably is the only cause. So all of us know, this population knows actually the difference in circulating tumor cells and DNA. DNA has been used very widely, very routinely in knowing actually what is the last line of a treatment in metastatic cancers. Like one cell has 1080 genes panel. But circulating tumor cells probably is not used for treatment decision except in few components like colorectal cancer and breast cancer, and I think today's objective is actually talk about lung cancer. So what has been the past of circulating tumor cells? 2004. Imagine innovators, probably they were working on this kind of components, designing materials to capture circulating tumor cells, and US FDA approved this in 2004 for probability of overall survival percentage detection, as you see on the y-axis. And in metastatic conditions, I think the dismal overall survival is absolutely known as a prognostication in breast cancer, colorectal cancer, and prostate cancer. Later on, what happened, the importance of CTC went down because we wanted to evaluate its role in early cancers, not only prognostication in metastatic cancer. And I'm very proud and humbled to say that today we have done 8,000 cancer patients in early stage detection in India here. And we are providing data to the world actually not in the metastatic but in other regimens. If you look, I love this actually Cohen's review. There are three possibilities that the patients, whether you detect them early or treat them well, they are going to actually get into the primary resistance, and that's the holy grail of actually oncology. The patients actually, they respond well and they could recurrent. And the best scenario is actually the remission you can be detecting by this DNA. This is a wonderful review. The challenge, as I mentioned, is to find one culprit among billions of a cell. If I'm a chemical engineer, I can tell you that philosophy of Gandhian engineering is very simple. Do great with minimal components for many people. And if you look on the components here, there are many components. And how do you design this kind of antibodies and materials which can specifically capture epithelial cells is a wonder of actually this kind of engineering. We are the first Indian company which got a medical device approval by DCGI and CDSO after several years of actually clinical trials in Tata Memorial Hospital with Dr. Pankaj and Dr. Kumar. The importance of CTC from cytokeratin was known, but the ability to detect actually other protein markers like PD-L1, HER2, and so many markers can be done in our Pune lab today in 4.5 years of a time. To set the context, I think these three components are important. On the right-hand side, the dismal outcome with if both the biomarkers are actually present. This has been shown in breast cancer, this has been shown in colorectal cancer, and this can be shown in the lung cancer. But unfortunately, philosophically, lung actually does not allow CTC to disseminate as good as actually other cancers. And I think most important innovation that I'm talking about will if we compare actually ctDNA from the tissue or the blood and from circulating tumor cells through the technology that we just launched at ESLB a month back, captures and releases the cell. And we have done now 1,200 patients CTC, live CTCs, true CTCs, and the whole genome amplification. And this data is phenomenal and discordance to that of a ctDNA. I dare to say it first time today that the dependency on tissue and blood gives 40% probability of a patient to actually have an overall survival. The data coming from those disseminated cells from circulating tumor cells is not in concordance with this because of a pooling open data. And I will say actually, and pause in few minutes, if you look, when we had a paired sample from ctDNA from the same patient, about 20 to 25% times you cannot detect mutations because of a sensitivity limit today. And that will continue for another decade or so, unless engineers do something great. So they cannot avail actually your modern companion diagnostic treatments, even if they are expensive, especially in the Western world. What we found in this patient, we get circulating tumor cells. And if you look on the right-hand side, broad mutational profile, probably is very concordant. And in a pancreatic study, that's what we are doing in a medical school, Wisconsin and Stanford at HCC, we find a very differential information. Now, interesting is that in clinical trials, especially in inducting new patients, is very challenging, delayed, and very expensive. So protein markers like PD-L1 or HER2 on these live cells can be very important for the patients. And I think I will go back to one of longitudinal monitoring of our own patients from your clinics in 265. This is called as a J and A quadrant. This is like Jack of all quadrant or Jayant or Arvidan quadrant. What we find that patients who had actually both this biomarker present were about 50% in lung cancer. On the right hand side quadrant 2, almost like 25% patient had either of the biomarkers. If ctDNA is negative, great. I think you don't have a localized tumor. But if CTC is positive, I think there is a chance of a recurrence. If you look at a third quadrant where ctDNA is positive, that means there is actually a residual disease, and CTC negative, that means the patient do not have a disease in the circulation. So monitoring these patients is very important, and the last summary is that if patients do not have a ctDNA as well as negative, I think that's the best exceptional responders. Thank you very much.